Welcome to The Explainer. Today, we're cutting right through the noise and looking at the hard clinical data on addiction recovery. We're going to unpack the actual science of why relapse happens and, more importantly, how evidence-based tools can prevent it. So, let's just dive right into the facts.
We're starting with what is probably the most common and honestly the most damaging misconception out there. Does a return to use mean the treatment just completely failed, or that someone is somehow incapable of sustained recovery? You know, when families face this, absolute panic usually sets in. But the clinical data points to a very clear, very reassuring no.
To really understand why, we have to look at the foundational science. The National Institute on Drug Abuse actually classifies addiction as a chronic brain disorder. Because of that, the relapse rates for substance use disorders sit right between 40 and 60%. Now, I know that number might sound super high if you're expecting a one-and-done magical cure, but it completely shifts the paradigm of how we should view the entire recovery journey.
Let's put that 40 to 60% into perspective, because it helps to look at how it compares to symptom recurrence in other chronic conditions. Think about type 2 diabetes. That has a recurrence rate of 30 to 50%. Asthma? That's between 50 and 70%. Addiction fits right smack in the middle of these clinical expectations. It totally frames a return to use not as some moral failure, but as a medical event. It's a return of symptoms in a chronic disease that signals a need for more clinical work, not a reason to just give up.
Okay, so what actually drives that medical recurrence? Well, the source data points to four major, often totally invisible triggers. Let's break them down.
Villain number one is an unaddressed dual diagnosis. SAMHSA research shows over 9 million adults in the U.S. have both a substance use disorder and a co-occurring mental health condition. If a program only treats the substance use but completely ignores underlying depression, severe anxiety, or PTSD, the risk of relapse literally skyrockets. This is exactly why the iRely recovery source material emphasizes assessing and treating mental health conditions concurrently from day one. You just have to remove this massive relapse driver right at the source.
Drivers 2 and 3 kind of go hand in hand: inadequate aftercare and environmental triggers. Imagine stepping out of a highly supportive residential facility and walking straight back into your old, unsupported daily life stressors. Neurologically speaking, familiar cues, the people, places, and things linked to past use, they activate the brain's reward circuitry, triggering intense cravings before your conscious mind can even hit the brakes. Without a heavily structured step-down plan, that transition becomes a huge clinical vulnerability.
And the fourth driver is PAWS, or Post-Acute Withdrawal Syndrome. It's this cluster of protracted symptoms, things like serious cognitive fog, sleep disruption, and extreme mood instability that can linger for weeks or even months after the acute withdrawal phase is over. The clinical guidelines stress how absolutely crucial it is to educate clients about PAWS well before discharge. If you don't, people misinterpret this totally normal physiological instability as proof they can't function without substances, which leads them right back to using.
So when is the danger highest? The overall high-risk window is those first 30 to 90 days post-treatment, but specifically the first 2 weeks following discharge. That is the absolute peak risk period, the red zone. This timeline proves exactly why a direct step down to intensive outpatient care is an absolute non-negotiable necessity. Going right back to a standard daily routine during this window is just incredibly dangerous.
With those risks clearly identified, how do the best facilities actually build lasting recovery? Let's unpack the Hero's Toolkit used to navigate safely past these traps. CBT, or cognitive behavioral therapy, is for sure the gold standard here. It's heavily utilized in both individual and group sessions at places like iRely to actively rewire how a person responds to triggers. The protocol walks you through identifying those sneaky automatic thoughts that pop up right before a slip, restructuring the cognitive distortions that try to rationalize it, and building real-world behavioral coping strategies. Ultimately, this all leads to a tangible, written, personalized prevention plan way before discharge day.
Now this next one is just fascinating. It's a technique called urge surfing, which is a core part of Mindfulness-Based Relapse Prevention, or MBRP. It's a clinically validated protocol by Dr. Sarah Bowen. Instead of fighting a craving, which honestly usually just gives it more power, clients learn to observe it as a passing mental event rather than a command that they have to obey. You just ride the wave of the urge until it breaks. Research in JAMA Psychiatry shows this specific skill significantly drops 12-month relapse rates by building a vital, life-saving pause between a craving and an action.
There's actually a massive clinical gap in how different programs handle discharge. Standard care usually scrambles at the very end to build an aftercare plan, which leaves a super dangerous gap during that critical 2-week window we talked about. But the front-loaded approach outlined in the iRely materials, they are solidifying outpatient therapy, support groups, and crisis plans starting in week 1 of residential treatment. It is a totally proactive methodology that takes all the panic out of discharge.
If you're in the support network for someone, you got to keep your eyes peeled for early warning signs, because relapse is a process, right? It's not a sudden event out of nowhere. Recognizing behavioral shifts, like major emotional volatility, skipping therapy, isolating from friends, or starting to romanticize past use, allows for early intervention long before a physical relapse ever happens. Identifying these shifts gives you the power to interrupt the momentum.
Okay, but what if a return to use has already occurred? First off, recovery is still completely possible. The absolutely essential clinical response is prompt re-engagement with treatment, not shame. The source materials make it clear that reaching out for a clinical assessment by addiction medicine professionals, like calling the iRely admissions team at 818-262-3537, is the quickest way to safely figure out the next appropriate level of care. I want to leave you with a truly game-changing shift in perspective from our source material today. Quote, "Relapse is not failure. It is clinical information about what additional work is needed." Seriously, how powerful is that? That single sentence fundamentally destigmatizes the entire recovery journey. It takes all the shame out of the equation and replaces it with actionable clinical purpose.
As the data shows, recovery is definitely not about perfection. It is an ongoing, deeply manageable clinical challenge. Once you really understand the science of triggers, post-acute withdrawal, and evidence-based therapies, relapse transforms from a failure into usable data. So, the big question is, how will you use this data to empower the very next phase of the journey? Thanks so much for hanging out with me for this explainer, and we'll catch you next time.